All right, let's get started. I want to welcome everyone to today's discussion, Be a Champion for Healthy Data. Glad you are taking some time out of your day to join this discussion. Before we get into today's topic, just a couple notes. We are recording today's presentation, and we'll be sending out a copy of the recording to those of you who are watching live within 24 hours of this presentation. You are all muted as attendees. However, we do want to hear what questions you have. So be sure to put those questions into the chat panel in GoToWebinar, and we'll answer as many as we can. All right, so I'm Jesse Eichhorn. I'm the Director of Product Marketing for Identity here at Lineate, and I want to introduce my two co-presenters today, Tammy Jones and Steve Kotick. Tammy, why don't I throw it over to you for a brief introduction?
Thanks, Jesse. Hi, I'm Tammy Jones. I'm Solution Consultant for the Health Term product line here at Lineate. Been in the terminology space for about 8 years, so I'm really happy to share insights and thoughts. Steve?
Hi, thank you, Tammy. I'm Steve Kotick. I am the Senior Solutions Consultant for the EMPI product, and I've been in the EMPI space for about 25 years.
All right, thank you, Tammy. Thank you, Steve. And now let's find out a little bit about who's joining us live today. We have a short poll for you that should pop up right in your GoToWebinar panel. We want to know what organization type you're from. You'll see a number of options there. Provider, healthcare technology provider, health information exchange, public health, or other. So we'll see if that that poll pops up. I'm not seeing it on my screen, but
the poll is up, Jesse. People are responding.
All right, that's great. Give it just a moment for everyone to log their answers, and then we'll take a look at the results.
I always think it's interesting to see who's attending from what kind of verticals. So I'm very interested to see what the results for this poll is, Jesse.
Yeah, I'm interested as well. Looking at who registered, we saw quite a diverse group of folks who signed up. So I'm looking at the results here. It's a little bit short on my screen, but it looks like we have a good mix of providers, healthcare technology providers, health information exchange. Good showing from that segment today. And a number from other. I imagine there's some folks from Lineate listening in. So good to know where everybody's coming from, a healthy mix across all the different segments throughout the healthcare space. And we'll be sure to be speaking to each of you in your unique situations as we go through the discussion today. So thanks for sharing that. All right, so before we do jump into the conversation of the day, I wanted to share a little bit about Lineate. We do have a number of folks who are current Lineate customers, some folks who are not. A little bit about Lineate. Lineate, we are interoperability experts. We're the developer of the Lineate Interoperability Suite, collection of solutions designed to help you exchange data throughout and outside of your organization, making that data exchange efficient, as well as enabling you with clean and healthy data. And that really ties into the conversation we're having today. Our primary focus is delivering solutions that allow you to have at your disposal actionable, healthy, clean data that you can then use for the various initiatives, strategic endeavors you have going on at your organization towards value-oriented results. So that's what we're all about here at Lineate. I do want to spend a moment here digging into the solutions that we're going to be focusing in on today, and those two solutions include identity and terminology. Many folks are probably familiar with what we say when we do say identity and terminology, but some of you may not be. So just wanted to spend one moment on a quick definition here before we jump in full force into the discussion. So Steve, can you tell us a little bit about what we mean when we say Lineate identity solutions here?
Sure, absolutely. Thank you, Jesse. Yeah, the identity management solutions that we provide are really focused on detecting discrepancies in records, either within a system or across systems. And that can either be a patient from the EMPI perspective or a provider or clinician from the provider registry side. And the way that we approach this is we use a very advanced probabilistic algorithm. And we layer on top of that a rules-based technology that is used primarily to identify false positives. You know, we've been in this space for probably 15 plus years as the company Nextgate, and the company founders and most of the employees have been around even longer than that through other companies. CBeyond, STC were the originating companies of this technology and this platform. So the key is that, you know, we have extensive experience in leveraging all of our, you know, deployment experience with both hospitals, HIEs, public health sector, number of different organization types within the healthcare space, even payers, to be able to identify, you know, those areas that, you know, you want to prevent false positives at all costs using the technology. And then we've recently introduced another layer of technology that is the referential data sets, and then that enables us to be able to automate the resolution of a lot of the data steward tasks that occur because they've either hit a false positive rule or they've you know, entered into kind of the moderate probability to low probability range, and those are typically ones that you would, you know, usually have a data steward look at, and we leverage referential resolution to automate that process.
Excellent. Thank you, Steve. That's great. Good primer for everyone on the line today. Want to move it over to Tammy. We talk about terminology solutions. Tammy, why don't you give a little bit of an overview as to what would be that?
Yeah, you know, terminology solutions are typically not a really well-known term throughout the industry, but what you do know is that you're having issues with trying to figure out what a code really means from a clinical data perspective. So what a terminology solution does is gives you the single source of truth to manage and maintain all of those content or those code sets. So like ICD-10 and SNOMED and LOINC and all the standards, this is really your central database to be able to really interact with that data, as well as taking your non-standard data and mapping that over to a standard. But it's really just your, it's almost an extension, I think, kind of the way that the identity solution thinks about patient records, where they're bringing in all of the patient records for a single best patient record, right? So you're bringing them all together in a way that's meaningful and relevant. But terminology solutions do the same type of thing, but with clinical concepts and codes. So we're going to bring that all into your single best code that's really relevant and accurate for the clinical data that you're seeing.
Excellent. That's a great overview, Tammy. Thank you. All right. So with those introductions complete and a little bit of an overview as to you know, the solutions we're going to be referencing today, let's pivot into the conversation topic for today. So be a champion for healthy data. You know, most of you on the line listening in today are involved one way or another with the exchange of data at your organizations. And you know, I think most of you, if not all of you, would agree with me that data is really the foundation of driving, you know, just about everything you do as an organization, whether that's, you know, ensuring, for those of you in health information exchange space, right, accurate, longitudinal oriented data from one organization to another. If you're in the provider space, you're delivering, you know, great patient care, et cetera. So, you know, it's really foundational to everything that you're doing, and as an interface or an integration professional, you're sort of at the forefront of making that happen. So the objective of today's call is to you know, point out some of the ways that your poor identity and terminology data can impact you know, some of the most strategic and important initiatives, you know, business drivers, you know, projects that may be going on at your organization that you might not be aware of or that you might be intimately involved with. So make you more knowledgeable about the potential impact of unhealthy data at your organization. We want to share with you some market information. Tammy and Steve are going to go into great depth about some of the use cases and some of the perspectives that will be helpful for you to know, and hopefully encourage you and leave you better prepared to engage with different folks, different committees within your organization, inquire about some of these things that we're talking today towards improving the overall quality of the data that your organization is curating, is managing, is exchanging, towards better outcomes. So we'll be talking about the end of this presentation, some of the ways that you can do that, some helpful questions you might want to ask. We also have a couple of resources we'll share with you as well to leave you as equipped as possible to have this conversation within your organization. So I talked about the different areas where poor identity and terminology data can have an impact. I'm sure a number of these resonate with you out there. These are very focused on the provider segment, the HIE segment, public health, things like improved care coordination or universal, making better strategic decisions with clean data, sort of universal across all the segments. However, for today's conversation, we're going to focus in on just 3 specific areas. 1 being clinical quality and analytics, 2 being patient engagement and the digital front door, and 3 being improved financial outcomes. So I'm going to go ahead and transition into clinical quality and analytics. And to kick off the meat of today's discussion, I'm going to pass it over to you, Steve. You have a really interesting and personal anecdote that you can share that really brings this challenge to life.
Thanks, Jesse. Yeah, this is near and dear to my heart. A couple of years ago, I had to go to one of our local hospitals here in the area that I live, and it was just a standard outpatient radiology exam that I need to go through. Went to the outpatient registration desk, registered, took all my information. First time I'd ever been to that hospital. And went through the test and everything was just fine, nothing wrong. And fast forward, just probably about 3 months later, I had come back from a mountain trip with my son, and we had basically climbed a very tall mountain, came back, 14-hour road trip, and a couple of weeks later, I was walking down the stairs at my workplace. All of a sudden, I get a sharp pain in my back, and I thought, oh, this is bad timing. I'm going out of town tonight. I've got to go try and figure out how am I going to get this adjusted. I thought it was a back problem. Went to my chiropractor and explained to him my symptoms. And he said, no, I think you have a pulmonary embolism. I think you need to go to the ER room immediately. And so it was very thankful that I had that encounter. Went over to the hospital that I had just gone to several months earlier, and went to the ER room and said, I think I have a pulmonary embolism. I'd like to, get checked out. And the registration clerk says, well, what's your name? I gave my name, Steve Kotick. And she goes, what's your address? I go 2513, and I gave my address. And she keeps on asking me all these detailed questions. Of course, I'm here, with a pulmonary embolism. And I said, I go, you should have me in the system. I was just here 3 months ago. And she said, well, sorry, I've got to ask all these questions, can't find you. So she goes ahead and registers me. I go, boy, this is just right up my alley. I've been doing this for 25 years, 1 patient, 1 record, right? Get the single best record. And what happens is that, I go through the treatment, everything came out fine. Lovenox is one of the key medicines that they treat you with when you have a pulmonary embolism. It's, to thin the blood very quickly. And so I was taking injections of that. And while I was, halfway through my stay, I developed an allergic reaction to Lovenox. So a little bit of a problem there. Obviously I charted that on my chart, but the reality is what's going to happen next time. When I come back, I've got 2 records at that hospital. What happens if they pick the wrong record? What happens if I'm presenting with another pulmonary embolism and maybe I'm not even communicative and they just get my driver's license? They look up my record. They find the other record has no reference to Lovenox. That's going to be the first course of action that they'll take, and lo and behold, I'm going to have an allergic reaction to it. So it's really critical, that the reality is when you have fragmented medical record numbers, you have clinical or potential clinical issues with those, patients that, you had information on one of the record that is not on the record that they're using when they're presenting for follow-up visits. So key point, very important, have accurate, patient records within your organization. Go ahead, Jesse, back to you.
That's very true, Steve. I appreciate you sharing that anecdote with everyone. We say safe patient care, quality patient care a lot, but an anecdote like this really brings that to life and into focus. And in this particular instance, as you noted, very much related to the quality of identity data at the organization. So I want to share with you all a few stats related to clinical quality and analysis. You may be aware of, you may not be aware of, but I think it further underscores the challenge that organizations have when it comes to this data. So 86% of nurses, physicians, and practitioners, said they witnessed or know of a medical error that was a result of patient misidentification, which is a tremendous number. And then 76% of lab data is not mapped to the standard LOINC coding. And this second point is related to terminology. And I wanted to get your perspectives, Tammy, in terms of the importance of clean terminology data as it relates to clinical quality and analysis.
Yeah, thanks, Jesse. When I saw this stat, the first time I saw it, I thought, that just seems crazy, right? That just seems like it's not possible. And as I've gone down the journey and really diving into terminology more and more, it's accurate, because most of the proprietary or the larger lab systems have their own proprietary code sets that they send. Some may or may not have some inclusion somewhere of the LOINC value that could be associated with that test or result, but oftentimes it's not the primary coding that they have that they send in the data stream. And to me, that's just astounding. So what happens when that data gets back to either an EMR, or maybe it's flowing all the way through to an HIE? I mean, this data is going to be non-standard, so it's going to, be hard to do analytics, and it's going to be difficult to understand what this data really means when you're looking at a patient record, for example. Is this meaningful to me as a clinician or somebody who's looking at those clinical quality measures and trying to put our numbers together to meet those measures? Those things are just a challenge. And so when I saw this data, obviously it was concerning to me, but I thought, there's great opportunity here. We can help organizations do this. But it felt like this data was kind of secondhand, right? Because I hadn't had that direct exposure to that. And just recently, as a matter of fact, in a conversation earlier this week, I talked with an HIE customer, and I know there's a couple of HIEs on the call today. And I asked them, because we were talking about the terminology solution, and I asked them what percentage of their overall incoming data, not just labs, but their overall incoming data, what percentage did they estimate was non-standard data? Meaning it wasn't initially coded to ICD-10 or SNOMED, CPT, any of the standard code systems. And they said between 40 and 50% of all their data, not just labs, was non-standard.
Wow.
So if you think about this for a minute, it's a pervasive, huge issue, but you think about what happens with that data as it's coming through. Maybe there's somebody that's sitting there all day long, every day, trying to resolve this data to a standard, trying to understand what this data is coming from a provider. It may not be just labs, it may be any participating organization that's feeding data into that. So here's a person now that's sitting there managing spreadsheets and where's it coming from, and is this a different code and a description for this from a different organization. Nothing is matching up, and how do we make it all make sense? These organizations are struggling with this on a daily basis. If that person who manages that spreadsheet needs to go out for an extended period of time, who's going to manage it? Who knows about this data? Who has visibility to this data? The ripple effect of non-standard data goes throughout organizations. And you, as maybe you're an integration professional and you're working in Rhapsody or CorePoint, maybe you don't see that too much. Maybe you do with correlation tables and any tables you would be like lookup tables you would be doing in Rhapsody. But there's one of your colleagues there that has been tasked with understanding or mapping this non-standard data to give you to drive or to populate these tables or these code correlations. There's somebody out there that is trying to manage this, and most likely it's a pain point. It's a big pain point. And that manual process and the human intervention really needed to complete this transformation to the standard really just scratches the surface of the issues that can reveal themselves when this non-standard data is identified. How long does it take to detect this non-standard data, and how long does it take to resolve that? So not only is it relevant when you're looking at a patient record, but it's also relevant for resources too. How much time and effort is spent trying to resolve this at the HIE or the provider level, the hospital level? There's so many implications to the data, but at least arming you with some information will help you maybe bubble up some of these conversations and expose where there could be pain points and how we can help you with a solution that can help resolve all of these non-standard codes to standards wherever and whatever they might be. Steve, I know you have a lot of great information about that 86% too.
Yes, it's interesting. You know, there was a Chime survey of all the CIOs in the healthcare Chime organization, and they actually only headed down at 19%. So there's obviously a disconnect sometimes between the frontline workers and the people that are up in the executive suite. So I think it's key to be able to recognize that that there are challenges out there. When I first started in this marketplace, probably right around 2000, 1999, 2000, within the EMPI space specifically, there, on average, we saw about 12% duplicate record rates, within a healthcare organization, and that was an average, right? By the time I got to about, I'd say 2017, that number had bumped up to, close to 17%. And so, it's interesting with the advances in technology and better systems, you actually are seeing an increase. Well, the reason behind that is because people are exchanging information. They don't control the governance or the provenance of the data that they're sometimes, required to steward once it gets into their healthcare organization. And these records are coming into systems that basically utilize very straightforward deterministic matching techniques, last name, first name, date of birth. And if you see any discrepancy, it gets kicked out to an exception queue, or it basically just goes in and they create another record within the system, thus creating another duplicate. Mergers and acquisitions are a huge contributor to the fact that we're seeing a lot higher duplicate percentage rate within organizations. So the key is really having advanced technology to both detect, resolve those records, and be able to streamline that in a way that is usable within the organization, not only within the healthcare setting, specifically acute care hospital systems, but then CRMs and all the other systems that are prevalent within organizations that are being used to reach out to the customer aspect of the patient that you just treated a few weeks ago. So it's very, very critical.
That's great. Tammy, Steve, great insight and great guidance. I want to do take the point you made earlier, Tammy, about, there's someone in your organization that's working on this. In the spirit of helping you be a champion for healthy data, we've prepared a couple questions that you might want to use as you're poking around at your organization, trying to get to the bottom of how you're addressing some of these challenges. So what is your strategy for sharing standardized information as required by cures? How's the data being connected across all of your clinical systems? And how are you handling non-standard codes like lab results? These are some introductory questions that might help you get to the bottom of what your organization is doing and help you find a way towards making that process even better. So with that, I'd like to transition over to topic 2 of 3 for today, patient engagement and the digital front door. Increasingly, we're talking to and working with organizations that are making more and more of an investment in how they interact with their patients, patient portals, pre-registration systems, et cetera. Underlying, the success of all of those efforts is, clean data that consumers can trust, that's accurate, and that really engenders, the type of relationship that these organizations want to have with their customers, with their patients. So let's dive into it. Steve, I'm going to pass it on over to you. And once again, you have a great anecdote to share, but this time it's from a study that you were involved with a while back.
Certainly, thanks, Jesse. And really the key with patient engagement and the digital front door is that you're putting more power into the patient's hand, right? And so to kind of segue off of the topic that we're addressing right now, there was another scenario where I was actually, it was during the COVID era, and we saw, just a meteoric surge of, the use of telehealth. And in a telehealth situation or telehealth, environment, you usually give the patient the ability to actually schedule themselves for a particular visit. And during that process, I was once again, it happened to be the same organization. I was scheduling myself for a visit, and I was trying to look myself up, and I wasn't found. So once again, I put my name in a little bit differently than obviously it was, registered. I maybe used the name Steve versus Steven, and that wasn't enough, or, did something, but they basically made me, re-enter all the information. Well, the challenge is that, because that's, the case, it left a real bad taste in my mouth. It's just, just a pain to have to, go through, entering in your information, and, especially when you're worried about the fact that there more than likely is going to be another duplicate record for me yet in the same organization. So with that in mind, I recognized that, even though this particular organization had a pretty, advanced system, in fact, they were deploying Epic throughout their entire organization, that, that this is probably just as prevalent even within some of the more advanced systems like Epic and Cerner in the marketplace. So I was involved in a different hospital system at the, for an engagement where they actually kind of engaged us to do a study of their EMPI. They had just recently gone through a conversion over to Epic within the year at their flagship hospital, and they had just brought on board 6 of their other hospitals. And so they'd gone through all of the effort that Epic requires to migrate over to Epic and get their duplicate percentage rate down to less than 1%, I think. And Epic had showed them actually at about a 0.625%. So this is 1 million patients across 6 hospitals, and only had a duplicate record rate of 0.625%. So the study really was to produce an extract, or not an extract of the Epic environments, and generate a report at the exact same time of all the duplicates that Epic had identified. So we knew exactly how many were identified at the point that the extract was taken. We did a thorough analysis using advanced probabilistic algorithms to evaluate the content of all of the patient records, and we identified that Epic had actually underreported their duplicate record rate by 325%, which is fairly significant. So they're under the impression they have a 0.625%, and in reality they were hovering probably in the 3.5% range. So pretty significant gap. And in addition to that, what we found in the analysis, part of the study was to actually review charts. Actually, before I go into the reviewing chart aspect of this, the other part of the analysis was to basically map when each of the patients were actually last seen. So, with every duplicate record, you have a last visit date. We determined that within the last year, they had about 7,500 duplicate records. And in reality, what we found within the EPIC, when we had reviewed the work that the HIM team had done within that last year, they had actually only identified and merged 3,500 duplicate records within that same time period. So we found that EPIC was really missing about 50% of the duplicate records that were, being created within the organization or being encountered within the organization. So a fairly significant gap there also. And the other aspect was the annual duplicate record creation rate, okay, and really that's a little bit different than what the existence rate is. Existence rate is usually what we normally quote when somebody asks you how many duplicate records do you have. Well, you look at your reports and say, this is how many I have in my system at this point in time. Well, that's actually across all the years of all of the records that they have collected, and that can span, easily 20, 30, 40 years at times. So the duplicate creation rate is actually the number of duplicate records that were identified based upon the number of patients you actually treated within that same time period. So within the last year, they had actually seen a 6.8% duplicate record rate during that time period. So fairly significant gaps. And the challenge is that EPIC's probably the best system in the marketplace. My opinion, based on the years that I've had experience in the hundreds of engagements that I've been involved in analyzing different systems, but EPIC and Cerner typically are on the higher end, and some of the older legacy systems are still really just using deterministic matching techniques to be able to locate their patient records. So they're underreporting, their duplicate record rates by even more. And for those that are either in the HIE space or in the healthcare IT space, and you're collecting information from these hospitals, if they have a legacy application other than the Cerner and EPIC, what I've found is that they're probably only seeing maybe 30 to 40% of the duplicates at best, and sometimes even less than that. So they're giving you dirty data. So you have to be aware of that so that you can put technology in place to identify where those discrepancies are occurring and be able to link and map those disparate records into a single best record for the patient.
That's great. A really detailed analysis of the study, some really insightful findings. And we do have customers. We work in partnership with EPIC at a number of organizations to help them move towards greater and greater identity data health. But these statistics are very important to consider for those of you, particularly in the provider space, integrating with large EHRs. So I want to share a couple stats like we did in the last section around patient engagement and the digital front door. 50% of consumers report that one bad digital experience with a healthcare provider ruins that entire experience. You may or may not have an engagement of your own that didn't meet your particular, didn't meet your standards. So in an increasingly competitive landscape, which most healthcare organizations find themselves in, ensuring that you maintain the trust of your customers is important, or else they'll look for somewhere else to find their care. 63% of patients say they'll switch healthcare providers if their payment experience doesn't cut it. So along the same lines, the payment experience is another facet of the overall engagement with your customers as a healthcare organization. So it also needs to be considered as you consider your holistic patient engagement strategy. And then 28% in 2020, 28% of patients switch providers because of a poor digital health experience. So all of these stats are sort of poking at the same concept, which is ensuring that you have the accurate data to support your communication with your customers. It is important in any industry, and very important in the healthcare space. I wanted to pass it over to you, Tammy, for your comments as it relates to terminology, patient engagement, and the digital front door.
Yeah, thanks, Jesse. I know you don't necessarily think terminology issues when you talk about patient engagement, but there are a couple of things to really think about. So, Steve talked about the merger and acquisition activities that could happen, and how the resolving and merging of those patient records was really important. And along the same vein, making sure that you successfully sync those the clinical data language that is speaking between the two organizations through a merger and acquisition, making sure those two are in sync, and again, providing that single best code for this encounter, this procedure, diagnosis, lab, whatever that might be. That's really important for patient engagement too, and ensuring that they have a positive experience with maybe the new organization, the one that is acquiring the existing one. The patient could really definitely suffer if those records merge successfully. That's great, but the aggregation of that data is really incomplete or inaccurate. So that standardization aspect and making sure that we're all singing from the same sheet of music or speaking the same clinical data language is really important. And it's important for not only the provider, but the patient too, because again, when we talk about the duplication of tests, it's not only a patient inconvenience to have to go do a duplicative test because maybe it wasn't codified right, you can't find it, whatever the situation might be, but it's not only just the inconvenience for the patient is now saying, well, why do I have to wait again? Because now I have to redo a test. And why don't you find all of the information from my previous provider or maybe organization? Why isn't it here in my record? And then now there's cost associated with that too. And I know we're going to talk about cost a little bit later, but all those things are going to play into the patient engagement. And it could be things from, my gosh, you go to an ER and you get a bill, and this is an actual news story that I saw probably about 2-3 months ago. It was a physician that fell while he was out on an icy patch. He slipped and fell. He badly injured his arm. He went to the ER. They examined, they x-rayed, they splinted, they gave him some Tylenol and sent him on his way and said, you'll go see the orthopedist. I mean, you all know the drill. You've probably all had an experience in the ER similar to that. Well, he received a bill several weeks later that was over $10,000 for an x-ray, a splint, and here's the bill. And he's saying, wait a second, I'm a physician. I think this is a little bit high. And his wife happened to be his office manager, and his wife said, oh no, I got this. Let me figure this one out. Tries to contact the hospital, and everything on the hospital bill was not coded to CPT. So here's a proprietary hospital code that she can't get real answers for. She doesn't know what it really means, what it relates to as being billable, reasonable, and customary charges. It took months to get that from the hospital. It took her months to get it. So suffice it to say, I mean, it all resolved at the end of the day. She was able to get the CPT codes. She identified an error in their coding that wasn't supported by the medical record. He didn't actually have this done, what they said he had done, and it lowered his bill over $2,000. So at the end of the day, that's a big difference. But his patient experience was so eroded from that as well. I mean, that's a big deal. You want to make sure that your patient experience is meaningful and easy and is, I guess, I want to say pain-free, but of course you're going to the doctor, so it's not typically pain-free, right? But the easier that patient experience and the less pain you can cause them, even during this entire billing process, all of those things, the more likely you are to retain that patient. And a happy patient is going to take the surveys and give you the good scores on the surveys. And you can see the trickle down. You know what happens next. So and just being able to give that patient more information, better information, relevant information the first time around instead of months down the road, isn't that worth something for a patient to keep them on your rolls, to keep them engaged, to keep them happy?
Tammy, just to throw one in there, is it's like adding insult to injury, right? The old cliche.
That's the absolute truth. I mean, it's it's such a cliche, but it really is true with this.
Absolutely. That's great. It's great how we were able to start with industry statistics here, and then Tammy really bring it down to an individual personal anecdote to really bring this to life. Really great discussion here with regard to patient engagement, digital front door. I want to segue once again to some suggested questions that you can shop around your organization to get to the bottom of what you're doing and maybe how to make it better. What initiatives are underway to drive digital engagement with patients? Pretty basic question there. Does your organization have a committee to manage these initiatives? And how are we ensuring that the current data being presented to patients is clean? What efforts are underway, what processes are underway, who's involved? All important things to know, and ways that you can evangelize the improvement of identity and terminology data at your organization. So with that, we're going to pivot to the third and final section of today's discussion. I do want to encourage those of you listening to the live recording here to put your questions into chat. A couple have come in so far, but please keep them coming. We're happy to tackle them at the end of the discussion here. So let's dive into it. Start out with a few statistics here to begin this section. 33% of all denied claims result of poor patient matching. And in this particular study, they were able to extrapolate out to how much that might cost the average hospital and the industry as a whole. Here's a surprising statistic. I was surprised to come across it. 50 to 65% of denied claims are never reworked. And then finally, each duplicate record cost healthcare organizations over $19.50 per inpatient stay due to redundant medical tests and procedures, if you sort of average them out over a period of time. So, these are pretty startling statistics here that have been, collected through a number of different studies and really speak to the importance of ensuring that, once again, your data is clean, your data is healthy, and it's being used to, not only power patient care, not only power patient engagement, but also ensure the bottom line stays healthy when it comes to revenue cycle management and financial outcomes. So before I actually move to this next section here, Tammy, why don't I throw it over to you first before moving over to Steve. Steve's going to be covering part 2 of the study that he presented in the last section. But Tammy, let me throw it over to you to talk a little bit about the intersection of terminology and financial outcomes.
Yeah, thanks, Jesse. So that second topic there, the 65% of denied claims are never reworked. To me, that was really surprising too. In 2016, there were approximately $3 trillion in claims submitted by hospitals, and that's a huge number, right? Of which 9% were initially denied for various reasons. The denials, they constituted about $262 billion in claims that were denied. 262 billion with a B. And Steve's stat that he has there about the patient matching relates to just that. We're talking about overall claims here. That denial rate climbed to 12% in 2021. So do the math, we got a lot there that's going on. And those denial reasons range anywhere from utilization issues like the prior auth issues, things like that, coverage, whether coverage was approved or denied with a certain health plan, incomplete information on the claim, and then coding errors. And I can really make the argument for a lot of these that all of these reasons that they highlighted specifically in the study that I saw have an element of terminology errors or coding errors to them. And specifically those coding errors in this study, those coding errors alone count for 15% of the denied claims. And again, huge numbers we're talking about. And that 50 to 65% of those denied claims that that aren't reworked, I mean, maybe it's because of dollar amount reasons or whatever, but most of those, if not all of those, could actually be recovered. It's not like they, oh yeah, this was submitted in error, it's a whole bunch of them. It's not that in reality. But one of the primary reasons that they might not be reworking a claim could be the cost. On average, healthcare providers spend about almost $120 per claim on appeals in rework costs. So it's going to cost me $118 to rework this claim. Is this claim worth it to me to try to recover this? Apparently, 50 to 65% of those are not worth it to them. So what would it take to get those claims to a state that you wouldn't have to rework? So how can we improve and make your first chance at, or your first run of that claim to be more accurate and to be more complete? And that terminology solution can really help drive that too. This is something that you can reference within all of your billing or any of your clinical documentation solutions or that are there currently in-house to ensure that you've got the right codes for the right procedures, the right diagnosis, the right labs, the right tests, how you've bundled it together. All of those things are really important to making sure that your claim goes through and isn't rejected or denied. You know, for some of these, yes, admittedly, the juice may not be worth the squeeze for some of these on an individual claim basis, but when you tie them all together and add them up, we're talking about real money. So if we talk about the 15% of that $262 billion in claims, that's almost $40 billion. And if your organization alone could recoup 15% of lost revenue, and you're the one to facilitate this and say, hey, I think I have a solution or a part of a solution, you'd definitely be the hero. So be the champion for that to improve the healthy data. And when we talk about whether it's clinical quality measures or analytics or the patient engagement, all of those things, bundle those all together along with denials. And that's a huge, huge, huge piece of your organizational revenue. Or where you're losing revenue, I should say. All of our organizations are being asked to do more with less. So using those Lineate tools that are at your disposal, because I'm sure there's a number of you that are already Lineate customers, use those tools that are at your disposal and we can help you identify that non-standard data and the source of the non-standard data and help drive some of these data quality initiatives, strategic initiatives, how to recoup this lost revenue. It's all right there for the taking, and this is just one way to help you get there.
That's great. Great guidance, Tammy. Thank you very much. Now let's take a look. I know we're approaching the top of the hour here in about 10 minutes, but I do want to revisit the study that you were talking about a few moments ago, Steve, and some of the findings that you had as it relates to financial performance.
Thanks, Jesse. Yes, and I'll try and kind of rifle through this one. But I mentioned earlier that part of the study that I had done was obviously first identifying the duplicate records. The second one was actually engaging an outside consulting organization of HIM professionals to actually go through and do a chart review. One of the criteria that we used on the chart review is that it had to be within the last year and it had to be clinically relevant. So we had to look at both the original record and the subsequent record. And of all the records, 7,500 that we found that were duplicated within the system, 16% of them actually had occurred within the last year, which is pretty significant, because a lot of times people say, oh, well, duplicate record could have been years ago and not relevant to the treatment today. Well, the reality is that there are a number of records that are, and you're going to run into obviously some clinical issues. And we did find and uncovered probably maybe 20 to 30 that we highlighted, cases where there was mistake, there were redundant tests that were performed. And so the following stats, Jesse, you want to pull the next one up? It's kind of to highlight, the additional costs associated with these redundant records at the time you're treating the patient. First of all, there was an actual direct revenue cycle impact. There's 72-hour remit rule was one of them. The other was that when the patient presented for treatment on the duplicate record, 10% of all of the duplicate records actually had an outstanding balance when the second person actually presented. So, and that average balance was $1,400, so you can, obviously imagine a number of those were probably in the thousands and thousands of dollars, and some might have been even less than 1,000, but on average, $1,400 outstanding balance in collectible revenue at the time the patient represented. So that's one, a missed opportunity, so to say. The next stat is that we found 12% had redundant lab tests. Now, lab tests are relatively inexpensive, but obviously, the redundant lab tests, were not, would not have been required if the other record had been available. So that's another key thing. And then the last a couple of stats I want to throw up is the 1% had redundant imaging studies. And this is much more costly. These are in the thousands of dollars range. Cost to the hospitals in the mid to upper hundreds, and that's raw cost of labor, professional services, equipment, and everything else. But the actual charges were in the thousands of dollars that were more than likely having to be written off. So that would have been revenue to the bottom line to the organization. And then the last one is that in the study, when we went through and did the clinical analysis, we did find that 5% of the duplicate records actually attributed or could be attributed to a clinical mistake or a clinical issue that patient faced because information that was pertinent to the treatment was on the other record. And a number of different war stories that I could throw out there, but for the sake of time, I'm just going to pass the control back over to our great MC, Jesse.
Thanks once again for sharing this, Steve. Yeah, we could certainly talk about this for a few more hours, I'm sure. But it's really great to see, in black and white here, some of the impact of duplicate identity data, and Tammy, what you shared about terminology and the impact it has on the bottom line of your organization. So really great stuff here. It's been a really fun and really far-ranging conversation that we've had today. So I want to conclude this section once again with a couple questions that you can ask. Do you have a breakdown of the reasons behind your denied claims? How are you addressing those claims? And then how are you resolving duplicate or erroneous patient identity data? It's pretty simple questions to get you started within your organization. And since that was topic 3 of 3, I'll do a little conclusion here, and then once again, I'll remind you, if you do have a question, drop it in the chat. We'll get to a few hopefully before the top of the hour. But I'd like to encourage all of you listening in today, whether live or the recording, to continue the conversation with us. We're here to help. We're passionate about this. We're experts in these areas. So, introduce us to your colleagues, bring us in. If you're just meeting and getting to know Lineate for the first time through this presentation here, feel free to reach out and connect. We'd love to talk with you, figure out what you've got going on and see how we might be able to guide you, assist you, and help you. We're planning a bunch more educational and informational sessions and content into the coming years. So we encourage you to stay plugged in and join what you can, what's of interest to you. And bring us in. Let us help create a business case for your organization. We can help you with the navigation that we've talked about during the session today. And finally, hot off the press, our new guide, Be a Champion for Healthy Data, modeled after the conversation that we had today, is now available. We'll be sending it to all of you listening in live, along with the recording of today's presentation. I think you'll find it helpful. It's a nice summary of the discussion we had today, and something that you can also use within your organization to put more attention on and hopefully get to the bottom of some of the identity and terminology challenges that you may be facing. So I want to thank everyone for sticking with us for the hour and listening into this great conversation. We did have a few questions come in. I think we can hit at least one of them here. One has to do with the EMPI and identity, and it might be best for you to tackle, Steve. If someone's wondering how the EMPI can help them, presuming this is coming from a provider organization, integrate EHR and EMR with a CRM like Salesforce.com.
Absolutely, great question. And we actually have a couple of clients that have done this. Obviously in the CRM environment, you're sometimes populating that with consumer-related data. So you're loading up commercially available information. Sometimes it's from a credit bureau of patients within your particular geographic region. And you don't necessarily want to load all that information into your EHR, whether it's a Cerner or an Epic, because it more than likely is just going to cause more challenges around identity management. So the best way to do this is to use the EMPI as the kind of the central identity management hub and feed information in from the Salesforce.com data set into the EMPI, and this can be done very easily with the Rhapsody or CorePoint engine using API calls into the EMPI, and then you have you load in the information from either your EHR or even health plans. I know a lot of organizations put in their health plan information if they have their own health plan into the EMPI and match up all of the records across members, across patients, across the consumer platform. And then that creates the central registry for that person's identity. So when a person then calls in and might want to have some sort of dialogue with someone in the help center or with someone within the call center, they've got the ability to be able to look up the individual in the consumer, Salesforce.com, and actually query data directly, from the other applications using our interoperability platform. So look up the patient, find out exactly what records that patient has, what maybe if they're a member of the health plan, pull that information in, and you have all the information at your fingertips, real time, up to date within Salesforce.com without having to populate all that information directly. So very solid use case on that.
That's great. Yeah, and you mentioned a number of customers that we're working with. Our customer Geisinger comes to mind. Not only are they a health system, they're a payer, and they manage the information exchange in Pennsylvania, and they're doing tremendous work as it relates to digital patient engagement. They, I think, like many organizations, recognize sending those proactive communications for health maintenance to get their customers coming back is critical. And they've shown tremendous results, both in terms of the degree to which they've minimized unhealthy data, unhealthy identity data, but also showing real results in terms of resource reallocation and cost savings implementing some of these solutions here. So yeah, this is great stuff. I'm looking at the time. We're at the top of the hour. So once again, I'd like to thank everyone for listening in. I'd like to thank my tremendous co-presenters, Steve Kotick, Tammy Jones, and for those listening live, we'll be sending along a copy of the Be a Champion for Healthy Data Guide, as well as a recording of this presentation. And I'll leave you with one further request to get in touch with us. We'd love to talk to you about what's going on at your organization and see how we can help. So thank you once again, and have a great day.
Thanks, Jesse.